Good afternoon to everyone. Welcome to you all for this 96 continuous medical education talk series organized by Faculty of Medicine, Biosciences and Nursing, MAHSA University. Today we have one speaker for today, and let me introduce the speaker of today, uh, Associate Professor Dr. Nizamuddin N.S.M.Abdul Aziz is a consultant obstetrician and gynecologist with 30 years of experience in clinical practice. After completing his training with the Ministry of Health Malaysia, he moved to work with the National Health Service in United Kingdom. After obtaining his membership of the Royal College of Obstetricians and Gynecologists, MRCOG, he returned to continue to serve the Ministry of Health Malaysia, and later he moved to private practice. He obtained his fellowship of the Royal College of Obstetricians and Gynecologists, FRCOG, in 2012. He currently holds the position of Associate Professor in Obstetrics and Gynecology at MAHSA University since March 2022 and is fully engaged in teaching ONG to MBBS students. He is also a member of Obstetrical and Gynecological Society of Malaysia. And without any further ado, I would like to invite the speaker of today, Associate Professor Dr. Nizamuddin, to talk on disorders of sex development. The floor is over to you, Prof. Thank you.
Thank you very much, Prof. Suresh, for your kind words, for your lovely introduction. A very good afternoon to you, ladies and gentlemen. Welcome to the 96th CME program. My name is Nizam, representing the ONG department of the Faculty of Medicine, MAHSA. Today, we are going to have a review of the disorders of sex development. And I chose this topic because although the disorders may be rare, but nevertheless, they cause a considerable amount of distress, both to the mother, the father, as well as the patients. And therefore, we as healthcare personnel should have some idea on how to approach a case of DSD. Now, with that objective in mind, the scope of discussion will cover the development of the male as well as the female gonads, the classification of DSD, the clinical presentation, the investigations, as well as treatment. It's a very vast topic, and there are plenty of slides. So let's get cracking. Right. Genetic sex is determined at the time of fertilization, whether one inherits the X or Y chromosome from the sperms. That's basic. The initially gonads, which are derivatives of the mesenchyme, appear as a genital ridge on either side of the midline. And in the early embryonic development, the gonads are undifferentiated or bipotential. What I'm trying to say is that in the early embryonic development, the gonads have the capacity to develop either as the ovary or as a testis. But by 6 weeks of embryonal life, the presence of SRY gene in the Y chromosome will direct the bipotential gonad to develop into the testis. The testis then gets populated with two kinds of cells, the Sertoli cells as well as the Leydig cells. The Sertoli cells secrete anti-Mullerian hormones that will cause regression of the Mullerian ducts, whereas the Leydig cells will secrete testosterones, which will develop the Wolffian ducts into the male internal genitalia. That's the epididymis, the vas deferens, as well as the seminal vesicles. And the testosterones will get converted to the more active component, the dihydrotestosterones, which will cause the development of the male external genitalia, the glans penis, the scrotum, as well as the penile urethra. At the same time, the testosterones can have a psychosexual effect on the male brain to confer an individual a male gender identity. Now, what about females? In the absence of Y chromosome, the bipotential gonad will develop into the ovary. Ovary secretes no anti-Mullerian hormone, neither does it secrete testosterones. And because there is no anti-Mullerian hormones, the Mullerian ducts will continue to develop into the female internal organs, namely the tubes, the uterus, the cervix, and the upper part of the vagina. And in the absence of testosterone, there's regression of the Wolffian duct, and female external genitalia will develop, namely the clitoris, the labia majora, labia minora, as well as the vagina. Now, this is a model that we've studied in the past, but in the last decade, with the advances in molecular technology, molecular science, there has been many other genes that have been discovered that controls the development of not only the testes, but also the ovaries. For example, now we know that SRY gene, the sex-determining region of the Y chromosome, acts to increase the expression of SOX9, SRY box9, right? Which in turn will control the development of the testes. And SRY genes gets multiple feedbacks, positive feedbacks from numerous or various other types of genes in blue, like WT1, Wilms tumor suppressor gene 1, GATA4, SRY box 3, and so on. At the same time, ovary is no longer regarded as a default pathway. In other words, there are many genes that actively participate in the development of the ovary. For example, FOXL2, FOXH8 transcription factor 2, R-spondylin1, beta-catenin, and so on. And mutations can occur in any one of these genes that can cause disorders of sex development or DSD. Allow me to just say DSD for short for the purpose of this discussion. And they not only cause DSDs, but mutations of these genes can be associated with specific syndromes. For example, Sercal syndrome associated with WNT4 mutation, sex reversal, adrenal, kidneys, as well as lung dysgenesis. BEEPS1, blepharophimosis, ptosis, epicanthus inversus associated with FOXL2 mutation. This one we might have heard, campomelic dysplasia and gonadal dysgenesis associated with SOX9 mutation. And the other syndromes, Danish-Drush, Fraser syndrome, and Weger's syndrome associated with Wilms tumor suppressing gene 1 mutation. Now, the idea of putting forward these syndromes is to emphasize the fact that DSDs may not necessarily be an isolated event, but they may be part of a larger syndrome. So the key points here in embryology would be SRY genes, along with the pro-testis genes, will direct the bipotential gonad to become the testis, to develop into the testis. And in the absence of SRY genes, as well as in the combination of the so-called pro-ovarian genes, the gonads will develop into the ovaries. Testosterones, presence of which is necessary for the Wolffian ducts to differentiate. And in the absence of testosterone, the Wolffian ducts will regress. Anti-Mullerian hormone, the presence of which will lead to the Mullerian duct regression. And in the absence of anti-Mullerian hormones, the Mullerian duct will develop into the female internal genitalia. Now, how do we define DSDs? The DSDs are defined as a congenital disorder that is characterized by atypical development of either the chromosomal sex, the gonadal sex, or the anatomic or phenotypic sex. It occurs due to either disruption in the gonadal differentiation or development, or if there is a disruption in the sex steroid production, sex steroid conversion, or even in tissue utilization of the sex steroids. What's the incidence? Well, the incidence of ambiguous genitalia is about 1 in 20,100 to 4,500. Congenital adrenal hyperplasia, which is the commonest variety of DSD, the incidence is about 1 in 10,000 to 15,000. And the XY DSD is about 6.4 per 100,000. Rather rare. And the incidence varies with ethnic group, with the highest incidence seen in South African population. Right. Look at the presentation. They may present with a myriad of symptoms, from ambiguous genitalia at birth to ambiguous genitalia in childhood, family history, right, of siblings affected, or the congenital adrenal hyperplasia may present as a medical emergency, soul-losing crisis in the neonatal life. Inguinal hernias, in fact, if you see any baby girls with bilateral inguinal hernias, you should raise a red flag that you may be dealing with a DSD. So that's another presentation, or a pelvic mass and a pelvic tumor. Or they may present later on in their lives. At the time of puberty, the mother may bring the child with primary amenorrhea, or delayed puberty, infertility, or even sexual dysfunction. Right. Now, in the past, we have heard terms like male and female pseudohermaphroditism, testicular feminizing syndrome, or even terms like this one, intersex. Imagine going to a mother and telling the mother, look, your baby is neither a boy nor a girl, but in between, intersex. Such terms can be very disappointing, very disgraceful, demeaning, derogatory, right? So in the consensus of opinion in 2005, among the various endocrinological societies globally, these terms were abandoned, were shelved. And all of these disorders were grouped as one disorder, DSD, disorders of sex development. And they're classified as such. As you can see here, DSDs involving the XX individual, DSDs involving the XY individual, sex chromosomal DSDs, disorders of gonadal development, persistent Mullerian-Dutt syndrome, and malformation syndrome. Now, very obviously, we can't go through everything. So we will try to pick and choose the DSDs that present with ambiguous genitalia. Now, the DSDs associated with XX individual usually occurs when the fetus is exposed to excess androgens in utero. And the commonest example will be the virilizing form of congenital adrenal hyperplasia. But excessive androgen in utero can also occur when there is maternal androgen tumor, for example, Leydig cell tumor, or when the fetus is exposed to maternal consumption of drugs that are androgenic in origin. And the most common example will be danazol, as far as gynecology is concerned, which we use for the treatment of endometriosis, androgenic in origin, and that can cause virilization of the female fetus. Because danazol is no longer available in this country. XYDSD, again, many, but we will just concentrate on a few. On the disorders of testosterone receptor, that's androgen insensitivity syndrome, and disorders that cause a reduction in the enzymes or hormones, 5-alpha reductase deficiency, 17-beta hydroxysteroid dehydrogenase type 3. I know that's a mouthful, so just allow me to say HSD, 17-HSD deficiency, as well as the congenital lipoid adrenal hyperplasia. Sex chromosomal DSD, there are a few. We will not discuss this because they do not present as ambiguous genitalia, but the common ones include Turner syndrome as well as the Klinefelter syndrome. We may need to discuss these disorders of gonadal development or maldevelopment of the gonads involving the XY individual and the XX individual, persistent Mullerian-Dutt syndrome, if we have time, we will discuss that, and a host of malformation syndrome, which is beyond the scope of this discussion. Right, let's take a look at congenital adrenal hyperplasia, CAH. Now, that's the most common etiology of ambiguous genitalia in a newborn. In fact, 50% of the cases of ambiguous genitalia is due to congenital adrenal hyperplasia. It's an autosomal recessive disease with the incidence of 1 in 10 to 1 in 15,000. And it has a higher predilection among the Hispanics as well as the Ashkenazi Jews. In 90% of the cases, it's due to deficiency of this particular enzyme 21 hydroxylase that's involved in steroidogenesis. And in the remaining 10%, either 11 beta hydroxylase deficiency or 3 beta HSD deficiency. Now, in 21 hydroxylase deficiency, there's a block here and here. This is the biosynthetic pathway of hormones. I'm sure you remember adrenal hormones. Zona glomerulosa, secreting the aldosterone or mineralocorticoid. Zona fasciculata, the corticosteroids, and zona reticularis, the sex hormones. So in 21 hydroxylase deficiency, there is a block here in the conversion where there's a block in the conversion of 17-hydroxyprogesterone to deoxycortisol. And the substrate that accumulates 17-hydroxyprogesterone gets shunted to form testosterone that causes virilization of the fetus. And because there is aldosterone insufficiency as well as cortical insufficiency, there is salt-losing crisis in infancy. The second one is the 11-beta hydroxylase deficiency that causes a buildup of 11-deoxycortisol. But contrary to the previous one, 11-deoxycortisol has mineralocorticoid activity, and therefore it causes salt retention as well as hypertension, as opposed to 21-hydroxylase that causes salt loss and hypotension. Right. How do they present CAH? In 2/3 of the individuals, they present as a salt-losing crisis in infancy, in neonate, and they present with hyponatremia, hypotension, dehydration, hyperkalemia, as well as hypoglycemia due to cortisol deficiency. Right, that's wasting crisis. The XX fetuses, the female fetuses, because of the excess androgen, become virilized to a variable extent at birth, ranging from clitoromegaly to hypospadias to chordee, and even to fusion of the labioscrotal folds. They may present in childhood with varying degree of virilization and accelerated growth, but eventual early fusion of the epiphysis leading to a final restriction of the adult height. Or they may be the very mild variety presenting with late onset hirsutism and oligomenorrhea. Right. Okay, ladies and gentlemen, can you guess what will be the first question the parents will ask you? Well, I suppose you guessed right. Doctor, is my baby a boy or a girl? Right? This is congenital adrenal hyperplasia of an XX individual, baby girl, with ambiguous genitalia. Note clitoromegaly, almost like a mini phallus. Note fusion of the labioscrotal fold as well as labia minora, visible, ambiguous genitalia. As I mentioned, 2/3 of the individuals will present as a salt-losing nephropathy. It is difficult to recognize this condition in males because virilization is not an issue in males. They will be asymptomatic, they will be discharged, only to be readmitted 2 to 3 weeks later with full-fledged symptoms of adrenal insufficiency, vomiting, poor tone, poor feet, as well as dehydration, hypoglycemia, hyponatremia, and so on, right? Or they may present in later part of their lives with premature masculinization and accelerated physical growth, untreated with lead to cardiovascular collapse and neonatal death. The 11-beta hydroxylase variety we have already mentioned, we have discussed, presents as a salt retention variety, hypertension, as well as ambiguous genitalia. And the mildest form is the 3-beta HST variety deficiency that present with a lesser degree of virilization, but salt-losing crisis. How do we diagnose? Well, full examination is necessary, including assessment of the infant for salt-losing crisis. You can do the use and ease, check for plasma sodium as well as potassium, and estimate the 17-hydroxyprogesterone level, which is increased in CAH. We can do the imaging technique. We can do an ultrasound to locate the uterus or the gonads, but the uterus may be difficult to image in the early stages of life, simply because it has not been stimulated by estrogens. So the alternative imaging modality or technique would be an MRI, right? And finally, we can do karyotyping to see whether it's an XX or XY, and DNA sequencing of the genes, the 2 genes here, either in the form of Sanger's sequencing or whole exome sequencing, to look for mutations. Management, it has to be a multidisciplinary team approach consisting of the various disciplines, the pediatricians, the neonatologists, the geneticists, the pediatric urologists, pediatric surgeons, ethicists, not to mention the gynecologists, not to forget the gynecologists, as well as perhaps religious clerics, because they are the ones who can give their religious point of view regarding ambiguous genitalia, right? Urgent replacement of glucocorticoids, which will not only replace the cortisol deficiency, but will also suppress the pituitary ACTH and will then subsequently reduce the adrenal androgens. And glucocorticoids can be in the form of DEXA, hydrocortisone, or prednisolone. Aldosterone has to be replaced by fludrocortisone. And at a certain point in their lives, one may need to consider feminizing surgery, feminizing genitoplasty, to try to reduce the size of the clitoris to make it more concordant with the external genitalia. Can they get pregnant? Most certainly they can. But in pregnancy, although subfertility may be a rule, they can get pregnant. And in pregnancy, the requirements for both glucocorticoids as well as mineralocorticoids increase. And what about prenatal diagnosis? Is it possible? Yes, prenatal diagnosis is very possible if there is a history of affected siblings. Since I'm in gynecology, I'm quite interested in prenatal diagnosis. Let's have a look. There are 2 ways of diagnosing fetus in utero that may be affected with this disease or this disorder, the invasive and the non-invasive technique. But whichever technique is chosen, the important thing to remember is virilization occurs at 9 weeks and beyond. Therefore, if any intervention has to be started, any intervention has to be given, it has to be done before 9 weeks. Otherwise, it will render the exercise of prenatal diagnosis futile, right? Now, in the invasive technique, if the woman gives a history of the previous sibling being affected by congenital adrenal hyperplasia, She started immediately on dexamethasone. Dexamethasone will cross the placenta, will suppress the fetal pituitary gland, reduce the ACTH production, which will in turn reduce the adrenal androgens. This will reduce the degree of the virilization to a certain degree, right? And around about 11 weeks, a CVS, chorion villus sampling, is done, or around about 15 weeks, amniocentesis is done, and the gender is determined. If the fetus is a male gender, dexamethasone can be discontinued because virilization is not an issue in males. But if the gender is a female gender, then further testing has to be done, molecular analysis, genetic analysis, to see if the fetus is affected or not. If the female fetus is affected, the dexamethasone is continued throughout the pregnancy till delivery, right? Well, this is not without controversies. You can do the math. It's an autosomal recessive disease. 7 out of the 8 fetuses will be unnecessarily exposed to steroids. And for the remaining 1 fetus, the treatment is not actually for life-threatening salt crisis or whatever, but it is for virilization, right? And we all obstetricians are quite comfortable actually exposing the mothers to steroids for the purpose of maturing the fetal lungs in preterm delivery, but that's only a very short exposure, not like this throughout the pregnancy. There are side effects to the mother, diabetes, hypertension, weight gain, edema, as well as reported side effects. Prolonged exposure of steroids can cause side effects to the fetus. Cleft lip, cleft palate has been reported, fetal growth restriction, as well as concerns about impact neuronal development. So the consensus of opinion is, among the professional endocrine societies, this intervention should be confined to clinical trials. What about alternatives? Well, we have other alternatives, non-invasive prenatal technique or non-invasive prenatal diagnosis that relies on the fact that cell-free fetal DNA can be extracted from the maternal plasma in the very early stage of pregnancy, as early as in the first trimester. So if there's a family history of a child being affected with CAH, these cells, fetal cells in the maternal plasma, cell-free fetal DNA, can be extracted, and with the information obtained from paternal as well as maternal inheritance and paternal and maternal haplotype pattern, the fetuses that are affected can be identified and started on dexamethasone, right? This is the first study that was published in the Journal of Clinical Endocrinical Metabolism that states that massive parallel sequencing on 3.6 mils of a plasma from pregnant mothers can potentially provide the diagnosis of CAH non-invasively and before 9 weeks. Subsequently, in the same year, there was another report that gave a good accuracy rate of 96 to 97% for maternal and paternal alleles, respectively. And further reports were published later. All right, let's take a look at the cost. Now, this is a report in the prenatal diagnosis in an NHS hospital in a research setup. The cost for invasive testing would be around about £800, and the cost for non-invasive prenatal diagnosis, insofar as congenital adrenal hyperplasia is concerned, is about £1,400, roughly double. Now, despite all this, the take-up rate is not good for non-invasive prenatal diagnosis. There could be many reasons. One is that NIPD has been well established for autosomal dominant conditions, achondroplasia, thanatophoric dysplasia, but not so well established for autosomal recessive conditions like CAH. That's number one. Cost factor is number two. And the disease is rare, and therefore it's hard to get batches together to run the test so that the cost can be controlled. And the other important factor to consider here is that despite the reports that I've shown, our labs struggle to extract sufficient quantity of cell-free fetal DNA before 9 weeks. And therefore, they find this test difficult to do. So in conclusion, although NIPD is promising, obviously more work needs to be done before the test can be widely available. Let's discuss newborn screening. Is it possible? Most certainly. And there are many countries that offer newborn screening for congenital adrenal hyperplasia. I think New Zealand was the first to offer. This is the United States, Tokyo, right? And in more than 50 countries. What do? When the child is 2 days old or beyond, a spot of blood is taken from the heel prick, and that spot of blood is subjected to 17 hydroxyprogesterone level estimation. And based on the level, as well as based on the birth weight of the baby, The test can be classified as serum negative, requiring no further action, borderline, requiring perhaps a repeat test, or screen positive that may necessitate urgent referral to sort out the issue. Now, as I was saying, for the females, it is easy to diagnose because of some degree of ambiguity. And this test, I think, will be very useful for males who are asymptomatic, discharged, only to be readmitted with a full-fledged adrenal insufficiency. In our country, we don't have screening for CAH, but we have screening for newborn screening for some other more established conditions, hypothyroidism, G6PD deficiency, and so on. Right. So that's CAH. Let's talk about the next issue, androgen insensitivity syndrome, AIS for short. This occurs in an XY individual, and AIS occurs due to a defect in the androgen receptor. The testosterones are produced normally, but they are unable to act on the Wolffian dot. So the male internal structure is not developed, right? And they are unable to act on the external genitalia, and therefore it is a female external genitalia that develops. It occurs as a result of the mutation in the AR gene, and AR gene is located in the X chromosome, right? The disease is transmitted as an X-linked recessive pattern of Mendelian inheritance in 2/3 of the individual, and in the remaining 1/3, the disease occurs by mutation de novo, right? The incidence is rather rare, 1 in 20,000 to 1 in 60,000. There are different varieties. In a complete variety, complete AIS, there is complete absence of androgen receptor activity, right? So the baby born, the child born is unambiguously female phenotype, and they come later during puberty with primary amenorrhea and on examination and delayed puberty. And on examination, the vagina is present, but it is short or blind. The axillary hair and pubic hair is absent because the testosterone are functionless, and the axillary hair depends on the testosterone, right? But there is a good breast development. This is a very important clinical feature, good breast development, poor axillary hair and pubic hair. They may have bilateral inguinal hernia, absence of Wolffian dot because testosterone is functionless, but the anti-Mullerian hormones are produced normally, and therefore that causes complete regression of the Mullerian structures. There is a partial variety with partial androgen receptor activity, and you can imagine in partial variety there will be varying degree of under-virilization of the male, ranging from micropenis to cryptorchidism, hypospadias, and hernias, right? Here the testosterone will result in a variable development of the Mullerian dot because of the variable activity of the receptor, androgen receptor, but the anti-Mullerian hormones are normal in quantity, and that will result in a complete regression of the Mullerian structures. The mild variety will present, or the minimal variety will present just as a high-pitched voice and gynecomastia. Right. Allow me to bring to your attention the biochemical changes. All the sex steroid hormones, namely the androstenedione, the testosterone, as well as the dihydrotestosterone levels will be normal. And when HCG is given, say 5,000 units of HCG, that will stimulate the Leydig cells and increase the level of these hormones. And is genetic diagnosis possible? Yes, we can do a Sangus sequencing or whole exome sequencing, looking for mutations in the AR gene that is responsible for this disorder. How do we treat? That the risk of malignancy is very low, 2%. But the 2% is only for the complete variety, not for the partial variety. The partial variant has got a malignancy rate of more than 50%. So if you come across a complete androgen insensitivity with a testis malignancy rate of 2%, there is really no need to remove the testis immediately, right? We can leave the testis behind till puberty, because at puberty, the testis that is left behind will allow natural puberty to take place without the need of any HRT in the child, right? But after puberty, gonadectomy is offered because it becomes increasingly more difficult to monitor an intra-abdominal undescended testis. Following gonadectomy, we need to develop the female secondary sexual characteristics fully. So we start them on hormone replacement therapy consisting of estrogens, right? Testosterone may be added for the individuals to feel their best. And in these individuals, bone mineral density has to be monitored regularly, because in spite of estrogens as a HRT, osteopenia may develop, right? And once the individuals reach adulthood and sexual debut is anticipated, one may consider vaginal lengthening exercises in the form of dilators, graduated dilators of increasing length, which has been reported to have a success rate of almost 80 to 85% to allow satisfactory penetrative sexual intercourse without dyspareunia. So that's the advantage. No need for surgeries. Just vaginal dilators would do. And of course, if vaginal dilators fail, and then one may consider surgical vaginoplasty, either transperineal or increasingly nowadays laparoscopic. Right. The next disorder, three of them, we are going to discuss about the biosynthesis, the defects in the biosynthesis of steroid hormones. The first one is here, the very early stage of steroidogenesis or steroid biosynthesis, where there is a mutation of star protein, steroidogenic acute regulatory protein, right? This will result, block here will result in a complete shutdown of the adrenal glands and the gonadal tissues. The second one is 17-beta hydroxysteroid dehydrogenase deficiency that results in a block here, and 5-alpha reductase deficiency that results in a block here, right? Right. The first variety, 5-alpha reductase type 2 deficiency occurs because of the mutation of this particular genes, SRD5A2, which is located in chromosome 2, I think, right? This results in a block here. Testosterone fails to be converted to dihydrotestosterone. And if you can recollect what we have said earlier, THT is necessary for the development of the male external sex organs, the penis and the scrotum, as well as the glans penis. So in this absence, the child will be born female. The child will be raised as a female. She may even go to a boarding school, female boarding school. But as puberty knocks on her door, the testosterone level will surge, and that will convert to dihydrotestosterone by isoenzymes, and this female child will start to virilize, right? This beautiful young child will start to virilize. She will start developing male body hiatus, facial hair, body hair, and clitoromegaly. That's how distressing this disease can be to the child, and that's how upsetting this disease can be to the parents, right? Now, it's been described in a number of consanguineous families in Turkey, in New Guinea, as well as in the Dominican Republic, where this disease is called gouvernail, literally meaning failures at 12 in the local dialect, very aptly describing this condition. The second one is 17-beta HSD deficiency due to the mutation of this particular hormone, HSD17-beta 3, and that results in the block of androstenedione to testosterone. The clinical presentation is still the same, female phenotype or ambiguous genitalia with virilization at puberty. The third variety, congenital lipoid adrenal hyperplasia, where there's a block in the very early stage of steroid biosynthesis, and that's due to the mutation of star hormone, steroid acute regulatory proteins, right? And this will result in a complete shutdown of the adrenal glands and a complete shutdown of the gonads, or a global silencing, if I may say, right? And of course, that will present as a salt-losing crisis, and the accumulated cholesterol, which cannot be utilized, will accumulate the adrenal glands as well as the gonadal glands and cause failure in these organs, right? Now, I'm so sorry, this is a very busy slide. I've tried to put in tabulated forms, but let's try to look through the salient features. 17-beta HSD, 5-alpha reductase deficiency, as well as the lipoid CAH. All of them are inherited as autosomal recessive. All of them may either be females or ambiguous genitalia, but virilization can occur in these two varieties. The vagina is blind in all the three varieties. Mullerian ducts are absent in all the three varieties. Testes may be undescended across the board. Now, let's take a look at what happens at puberty over here, right? Now, in puberty, in 17-beta hydroxysteroid dehydrogenase deficiency, beta HSD deficiency, the accumulated androstenedione gets converted to estrogen, and therefore the breast development is variable here. Whereas in 5-alpha reductase deficiency, the testosterones are normal and they can oppose the action of androgen. They can oppose the action of estrogen, and therefore the breast development is absent. Now, that's very important clinically to distinguish between 5-alpha reductase and the 17-beta HSD variety. In one, the breast development is absent, and in the other, it's present. Androgen hair is present in both of these conditions. In the lipod variety, the breast development and androgen hair may be variable. Gender role in a 17-beta variety, HSD variety, as well as a 5-alpha reductase deficiency variant, there is a very high reported female to male gender change at puberty because of the virilization. Is genetic diagnosis possible? Most certainly. We can do a sequencing, either Sanger sequencing or a whole exome sequencing, looking for mutations of the genes that are responsible for these disorders. Allow me to bring to your attention the hormonal profile. That's quite important, I think, right? In the lipod variety, lipod CAH variety, as I said, there is global silencing of the adrenal hormones. Therefore, all the adrenal hormones are low, including the 17-hydroxyprogesterone level. In contrast to the classic CAH level, CAH variety, where the 17-hydroxyprogesterone levels are elevated, right? Now, let's take a look at the 17-beta HSD deficiency. Here, there's a block in the androstenedione to testosterone. Therefore, the testosterone levels are very low, androstenedione levels are very high, and the ratio, that's very important, the ratio of testosterone to androstenedione level is low, less than 0.9, and it remains low if the Leydig cells are stimulated with HCG. In 5-alpha reductase, the problem is with DHT. There's a low DHT. Testosterone may be normal. Therefore, the ratio of the testosterone to the DHT, which is low, is very high, more than 30. And if you stimulate the Leydig cells with HCG, in this condition, the ratio is exaggerated even more. Okay, right. Let's very quickly run through treatment. Now, in the 5-alpha reductase type 2 deficiency, we can apply topical DHT cream that has been reported to increase the hair growth, the facial hair, the body hair, as well as if applied in the pre-pubertal boys, there has been reported variable increase in the phallic size, the phallic growth. But I must be quick here to add that it doesn't work in normal individuals. So there you go. Okay, the gender assignment can either be a male or a female, depending on the degree of virilization, and it's really the job of a gender assignment team. However, if the individuals are raised as females, early gonadectomy has to be done before irreversible virilization occurs at puberty. And in a congenital lipid adrenal hyperplasia, as we mentioned, it's a salt-losing variant. It's a salt-losing disease, and patients have to be urgently replaced with physiological doses of glucocorticoids and mineralocorticoids. And when the puberty occurs, patients should be given sex hormones, either androgen or estrogen in concordance with the phenotypic sex. Right. We take a look at the next condition, disorders of gonadal development. There are two types, XY, disorders of gonadal development, and XX, disorders of gonadal development. The XY can be three types, complete, partial, and mixed gonadal dysgenesis. And the XX, disorders of gonadal development, can again be of three types, testicular, ovotesticular, and XX gonadal dysgenesis. Well, I agree with you. The terms are quite confusing. The terms are quite formidable in the first instance. But I'm pretty certain that if you sit down and try to recapitulate the names, you'll be able to get a good grasp of the nomenclature. Okay, so let's take a quick look at the XY disorders of gonadal dysgenesis. I'll try to tabulate this. We'll try to go through the salient features, right? Obviously, there are XY chromosomal makeup, XY in the pure variety. The pure variety was previously known as Swyer syndrome. We don't use these terms anymore nowadays, but the chromosome is XY in pure, XY again in partial, but mosaic, XOXY in a mixed gonadal dysgenesis. The gonad is streaked in the pure variety. In other words, it's replaced by the fibrous tissue. There is no Leydig cells. There is no Sertoli cells, no production of testosterone, estrogens, or anti-Mullerian hormone. Therefore, what is the presentation? They will be born as a female phenotype, and the parents will bring them in at puberty with primary amenorrhoea and delayed puberty because there is no hormones, no testosterone, no estrogens. And on examination, the child will be a female phenotype despite XY, blind vagina, no breast development because there's no estrogens, and because anti-Mullerian hormone is also absent, this XY child will have a uterus, right? Mullerian that well developed, Wolffian that absent. Now let's take a look at the other two. Now in the other two, in a mixed GD, one testis is one gonad is streaked, whereas the other one can either be normal or dysgenetic. Whereas in the partial GD, both the testes they're bilaterally streaked, right? So they may present either as a female phenotype, female at birth, or ambiguous genitalia. Well, in all the three varieties, the sex hormone levels are very much reduced. The testosterones, the estrogens, as well as the dihydrotestosterones are very much reduced. And because they are reduced, there is no negative feedback inhibition, and the pituitary gonadotrophin levels are increased. So FSH is increased, LH is increased, and the sex steroids reduced. How do you distinguish? Well, if there is presence of testicular function, either in the form of detectable testosterones or detectable anti-Mullerian hormone, that points to either the mixed or the partial variety. But however, the final diagnosis can only be obtained after histopathological examination of the testes removed prophylactically to prevent malignancy. Genetic diagnosis is possible either Sanger sequencing or whole exome sequencing, looking for the mutations that are responsible for this condition, either SF1, steroidogenic factor 1, SRY, sex-determining region of the Y chromosome, and MAP3K, that's a mitogenic activated protein kinase 1. Look for mutations in these genes. How do we treat? Well, the risk of gonadoblastoma is very high, 30% in these instances, and therefore gonadectomy is advised at the time of diagnosis, mainly done by laparoscopic these days. In the pure variety, the so-called Sway's syndrome is quite straightforward. They are unambiguously females that are assigned as a female gender, and therefore they are raised as females. In partial or mixed variety, they may either be raised as females or male. That depends on the gender assignment team evaluation. If they are assigned as females at the time of puberty, estrogens are given. And in this case, we have mentioned that uterus is also present. Therefore, once the breakthrough bleeding occurs, progesterone has to be added to protect the endometrium. And if they are raised as males at the time of puberty, hormone replacement therapy in the form of testosterone can be given. And at the time of sexual debut in adolescence, consideration is given to create a functional vagina. We have discussed that by using dilators or surgical vaginoplasty. Right. Now let's take a look at the last variant, the XX disorder of gonadal development. We talked about the XY previously. We talk about the XX now. Three types: the testicular DST, the ovotesticular DST, as well as the XX gonadal dysgenesis. I'm sorry. I'm sure you'll get used to the terminologies. Now, in the XX testicular DSTs, there is inappropriate activation of the testicular hormones in an XX individual. Therefore, they are fully masculinized, and the condition is then called de la Chapelle syndrome. However, the testis is small, it is azoospermic, and they have gynecomastia, very reminiscent of Klinefelter syndrome, except that they do not have that behavioral abnormality, and their intelligence quotient is normal. All the sex steroid hormones are low, testosterone, estrogen, and DHT, and because the sex steroid hormones are low, the negative feedback is lost and the gonadotrophin levels are high, FSH and LH. There are SRY positive in 90% of the individual. Biopsy will show absence of ovarian tissue, unlike ovotesticular DST. And these individuals are not at a risk of increased malignancy. Ovotesticular DSTs is the presence of both ovarian tissue as well as testicular tissue in a single individual. And the phenotype actually depends on the phenotype of the internal and external genitalia depends on the amount of functional testicular tissue, right? And because there's always some amount of functional testicular tissue, the gonadotrophin levels are normal and the sex steroid hormone levels may be normal. There are SRY negative in contrast to the previous variety, which is SRY positive, and biopsy will that most certainly show some ovarian follicles. That's why ovotesticular DST. And here there's a 5% risk of gonadoblastoma. And in the last variety, XX gonadal dysgenesis, there is mutation in the genes that control the development of the ovaries. And the clinical picture is very similar to XY gonadal dysgenesis, female phenotype coming in as primary amenorrhea, delayed puberty, infertility, presence of uterus, right? Again, the sex steroid hormones low, the gonadotrophin levels high, and genetic molecular analysis is possible. And if a biopsy is done, it will show streaked ovaries, right? We will give this a miss in the interest of time, right? We'll go to final uh, uh, part in the discussion, the general principles of management. I can't overemphasize that a multidisciplinary team approach is most certainly required, including all the professionals, including the psychologist, right? Psychologist is very important for psychological support and psychological evaluation, especially of a gender assignment team, as well as a religious cleric, right? Tests, you can do a urea and electrolytes. Use and is 17-hydroxyprogesterone, which is elevated in congenital adrenal hyperplasia. Check the gonadotrophins, check the sex steroid hormones, explore the ratios, testosterone to dihydrotestosterones, testosterone to androstenedione, stimulate the Leydig cells with HCG, and re-explore the ratios, right? Imaging, look for uterus, pelvic ultrasound, or MRI. And if a biopsy were to be done, histopathological examination of the gonad, right? And here, genetic testing has taken a very firm foothold in the last decade in the diagnosis of DSTs. We can start off with traditional karyotyping that can detect whether the baby is X or XY, aneuploidies, right? As well as mosaics, large deletions, and large duplications. If we are, say, interested in studying a segment of the Y chromosome, we can do FISH studies, fluorescent in situ hybridization, which can also detect sex chromosome mosaicism. Or we can move on to chromosomal microarray in the form of CGH, comparative genomic hybridization, that can detect submicroscopic deletions and submicroscopic duplications that fall below the threshold of detection by normal traditional karyotyping, right? Eventually, we may need to move on to massive parallel sequencing. We can try to sequence, say, all the disorders, all the exomes that are involved in the disorders of sex development or sex differentiation. That is called targeted exome sequencing. Or if that is normal, we can perhaps try to do whole exome sequencing. We try to exome everything, right? Exomes are actually parts of the DNA that codes for a particular protein. We can do the sequencing whole of it, and say if that is normal, then perhaps we can even think of sequencing the entire genome, right? The entire DNA. It's called whole genome sequencing. Most of the time, we do targeted or focused exome sequencing, and if that is normal, whole exome sequencing, that should be enough to derive the diagnosis. Right, gender assignment. Well, naming a child can be very pressing. We can be very pressurized by the parents, but it should never be rushed. Team approach is important, and parents should be adequately counseled, good support given, and education should be given. Well, the factors to consider when you assign a gender would be, well, number one, the phenotype, the appearance of the external genitalia, right? The fertility potential, the sexual potential, whether the problem is amenable to surgical correction, as well as views of the parents, familial views, cultural views, and very important here in this country, religious views. These are the things you need to take into consideration, right? Let's try to summarize it. X congenital adrenal hyperplasia, most of them are raised as females, right? And there is no reported cases of gender dysphoria, except where the virilization is extreme, in which case they may want to be brought up, the individuals may want to be brought up as males. In the complete AIS variety, they are phenotypically females. They have a vagina, they have a good breast development, they have a female mental or brain imprinting, they are raised as females. In the partial variety, partial androgen insensitivity, they may either be male or female depending on the degree of virilization. In 5-alpha reductase deficiency, they are usually raised as males. They may be raised as females, but usually males. And that's because the external genitalia responds to androgens. There is a high reported incidence of female to male conversion at puberty if it's not diagnosed. HRT may not be required because of the natural virilization if the testis is left in situ. Low grade of malignancy, low risk of malignancy, as well as the individual is very likely to have a male gender identity. Therefore, they're raised as males usually. And in the 17-beta HSD variety, they may be read as either males or females. But if virilization were to occur, that supports the decision to raise them as males. In the XY, gonadal dysgenesis, again straightforward, female phenotype. They have a uterus which can menstruate if hormones are given, so they are raised as females, right? They may also be psychosexually females. And in the mixed variety, they may be raised as males or females depending on the ductal anatomy, the phallic development, as well as the testicular function. Medical treatment, we have already done. Let me just summarize. CAH, we need to replace urgently with glucocorticoids, either hydrocortisone or DEXA or prednisolone, as well as fludrocortisone for the replacement of mineralocorticoid deficiency. If the individuals are hypogonadal and raised as males, they will require testosterone from puberty, perhaps even lifelong, and that can be given either as intramuscular injections, implants, or transdermal patches. If they are hypogonadal and raised as females, they will be given estrogen at the time of puberty, again orally, patches, implants, right? And if they have uterus, then after the breakthrough bleeding, progesterone has to be added to protect the endometrium from endometrial cancer. So what are the aims of HRT? In summary, the HRT is required to complete the development of the secondary sexual characteristic, to complete the pubertal growth spurt, to optimize the bone mineral density. These are the important aims. Also to optimize the muscle bulk, to complete the psychosexual maturation, as well as to attain social and sexual well-being, and to complete the uterine and phallic development. Now, finally, surgery. The aims of surgery would be obviously to relieve the parental distress, because when the parents are distressed, the doctors are also distressed. To make the ambiguous genitalia more compatible with the assigned gender, to preserve sexual and reproductive function, as well as to treat urinary obstruction, right? Now, the timing of surgery is controversial. If there's a urinary obstruction, obviously the timing has to be early. But previously, although surgery for correction was done early, now it has shifted to a stage where the patient herself or himself is able to understand and participate in decision making. We've talked a lot about surgeries in different sections, but let me just summarize. If there is a clitoromegaly, right? It's like, for example, in congenital adrenal hyperplasia, we can advocate clitoroplasty involving clitoridectomy with conservation of the neurovascular as well as erectile tissues. But this surgery is reserved for the more severe variety of clitoromegaly, Prader stage 3 and stage 4. Prader is a staging for virilization of an individual, right? Vaginal dilators and vaginoplasties for vaginal lengthening, we have already discussed it in the earlier section. What about phalloplasty? Well, unfortunately, unlike vaginoplasty, there is no erectile tissue available that can increase the size of an underdeveloped phallus. Because if such a tissue were to be available, our cosmetic surgeons will have a field day doing phalloplasty for every other man in town. Anyway, the counseling should focus on chordae repair, urethral reconstruction, testosterone supplementation, right? And gonadectomy is done early if the risk of malignancy is high. Now, let's take a look at the risk of malignancy. It's high in conditions like gonadal dysgenesis, right? XY gonadal dysgenesis, where the risk of malignancy is about 40%. Partial androgen insensitivity, 50%, as well as these syndromes that I've discussed earlier, Fraser, Danish thrush, very, very high. Intermediate risk of gonadal malignancy in 17 beta HSD variety. And in the complete variety, complete androgen insensitivity, the risk of malignancy is low, 2%. And that's the rationale of leaving the testes behind for natural puberty to occur. Therefore, the last slide in conclusion, DST with ambiguous genitalia is a very rare disorder requiring early investigation and urgent replacement, as well as early gender assignment. Complexity of the problem necessitates a multidisciplinary team assembly. The aims of management would be to provide a stable identity, to provide a good affirmative body image with good sexual function and fertility. Medical treatment can either be replacement of glucocorticoids, mineralocorticoids, or hormone replacement therapy in accordance or in concordance with the gender identity. Surgical corrections and surgical timing has to be individualized, and the risk of gonadal malignancy has to be assessed and gonadectomy appropriately timed. These are my references. Right, thank you very much for your kind attention.
Thank you so much, Prof, for covering
And
a broad range of different sex development disorders and the reasons for it, and how to early detect using modern techniques like exome sequencing, whole exome sequencing, or target exome sequencing, or whole genome sequencing, and possible non-surgical treatments and surgical treatments. It's excellent, the view, Prof. Thank you so
thank
much.
you very much, Prof. Thank you very
Um,
much. It's my pleasure, Prof.
Now, I would like to invite the participants if you would like to ask any questions to Professor Nizam.
Well, I think this topic can either be very, very interesting if you're interested in gynecology or in endocrinology, or it could be very, very boring if you're not interested in endocrinology. It just depends on how you look at it. Thank you so much. Thank you very much.
Any questions from the participants? Please leave your questions in the comment section, please.
Thank you, Miss Tiffany. It's my pleasure. Thank you, Prof. Mio. Professor Huck, it's my pleasure. Thank you so much. Prof. Razif, my pleasure. Thank you. Have a great weekend. Okay, Prof. Looks like my audiences are well satisfied and well informed, I hope.
Yeah, yes, Prof. I think looks very informative and they enjoyed the talk. And I think that there is no any further questions. I would like to thanks all the participants and very special thanks to you, Prof, for your excellent
It's
analysis.
my pleasure. Have a great weekend, all of you. Have a nice day.
Yes.
Thank you so much. Goodbye.